put up the slides. Okay, thank you, sir. All right, thank you for your time today as the Board of Commissioners, and thank you to our community members who are joining us for this COVID update. So today we'll provide a COVID-19 situational report, provide information on the revised vaccine prioritization that was released last week, and update you with information on the initial rollout of Phase 1A group and movement toward 1B. So we'll just start off with some of the data and graphs that we typically show. So cases have continued to climb since...
Stacie, I apologize for interrupting. I wanted to acknowledge we also have Dr. Hathaway from Mission Hospital here with us today. And Dr. Hathaway, were you planning on making any remarks as well? Okay, great. So I just wanted to acknowledge that'll be part of the discussion. Okay, please continue.
Thank you. So cases have continued to climb since November. What you're seeing now is the epi curve specific to us. We've currently identified 9,995 total cases of COVID-19 since pandemic start. So we are a day away from reaching 10,000. I have no doubt that we'll have more than 5 tomorrow. And so we saw a large increase post-Thanksgiving and continue to see those cases climb post-Christmas. This is definitely, you can see there, the largest surge of cases that we've experienced since the pandemic started. And just to note that the increases that we are seeing now are only just the beginning of the post-Christmas holiday cases that we are starting to see. And it is very highly likely that we will see a continued increase in cases as we get further into that incubation period. Trends in cases have not changed significantly. Cases cite gatherings with families and friends, both in the home and outside of the home, as in their investigations. Community sites and work sites. Cluster trends have not changed much either, with many still in the long-term care facilities, church service, medical offices, correctional centers, those types of places. We are currently seeing about 134 new cases per day that enter our public health workflow, and this has remained stable for the last 2 weeks. Our new cases per 100,000 per week after a week of stability has begun to increase again. We experienced a stabilization in new cases per 100,000 in the days just around Christmas and right after. And this was likely due, more than anything, due to fewer individuals seeking testing or seeking care on the holiday or shortly after, and then seeking that care a little bit after the holiday. And so we saw this indicator significantly begin to increase about 8 days after Christmas. Our current rate is 382 new cases per 100,000 per week. This visual that is provided for you on the screen shows the cases per 100,000 per week for the entire state. And you can see that, over time that has increased significantly, and the entire state is feeling sort of that heaviness of new cases as well. Percent positivity across the state. What you're seeing now is the statewide percent positivity graph, and that percent positivity across the state has continued to increase since Thanksgiving, with our current state rate at 16.5%. Record high percent positivity across the state, very indicative of increased community spread throughout our state and more viral spread. And just to give you the local perspective, locally the percent positivity also continues to rise. The percent positivity for Buncombe County as of today is 11.4%, over 10% at this point. That's up from 8.9 just last week. We did see a decrease in testing, as I mentioned, not many people going, so you had less people getting tested and only going if they really were feeling symptomatic and really thought they had it. So you start to see some of that being affected, but overall it's just that there's a lot of community spread, a lot of viral spread. And much like the map a couple slides ago, this just shows you what the percent positivity looks like across our state. Hospitalizations, additionally, the hospitalizations statewide continue to increase. Seen here, the daily number of people currently hospitalized with COVID-19 has been on a steady incline statewide since just after Thanksgiving. And many areas of the state started to see that right before Thanksgiving. And regionally, we don't look that different. We are seeing the same trend. Our Mission Hospital HCA representative, Dr. Hathaway, is here with us today, so he'll provide more of that information. I won't spend a lot of time on that today. These are our Buncombe County metrics that we've been monitoring over time. Many of our current metrics that we monitor remain red or orange at this time. Just a reminder that this data is pulled every Monday, so you're actually seeing it from the day prior, just so that we have some consistency. So the data here is reflective of January 4th. As mentioned earlier, the cases per 100,000 per week has increased by 8.8%. Our percent positivity has exceeded 10%, and now we saw that increase by 2.2 percentage points from last week. And testing, as I mentioned, in the community actually decreased. It's still well over what is expected or what is recommended, but we did see that decrease from about 3,600 per 100,000 last week to about 2,700. So again, that impact of the holidays is likely there. Deaths per 100,000 population saw a significant increase from previous week. This was actually due to a reporting failure from one of our facilities that a facility did not report their facility deaths in accordance to the guidance, which was within 24 hours, and did a bulk notification, which skewed that number immensely. And so just to let you know that we did send notification from the health director's desk to our long-term care facilities and other facilities to remind them of the requirement to notify us within 24 hours of a death. And that bulk notification is not acceptable. And then you'll see the hospital data that we track. And like I said, Dr. Hathaway is here with us, so I won't spend much time on that one. Now, you may remember a while back, before we had approved vaccine, that the North Carolina Department of Health and Human Services Vaccine Advisory Council had proposed an initial vaccination prioritization tool. It was had a lot of stratification on it, a lot of words. It was very busy, but it was very complete and comprehensive. And after Pfizer and Moderna were approved, the CDC and ACIP released their recommendations for vaccine prioritization. And just last week, North Carolina Department of Health and Human Services has aligned with those recommendations for continuity. And the revised prioritization plan, this plan replaces the previous plan that was tentative and said so in the vaccine plan for the state. And just to give you, Fletcher is going to go over our vaccine rollout, but just to give you some foundation here is that we are currently vaccinating in 1A. That did not change with the revision. The revision and the alignment starts with phase 1B, and that's where we see more of the change. And we'll be moving into 1B tentatively next week. And like I said, Fletcher will be providing more information. Highlights from this broad vaccination prioritization plan, that 1A remains that critical medical healthcare provider or support staff that are caring for, treating, assessing, evaluating, doing procedures on COVID-19 patients. Also, the medical first responders, vaccinating staff of the first wave of immunizations, and additionally, the long-term care facility residents and staff are in 1A. And just of note that there is a federal program that will vaccinate long-term care facilities. Many, all of the skilled nursing facilities within North Carolina and in Buncombe did enroll in the federal program. But, and so CVS and Walgreens will be responsible for vaccinating that population. That does leave still some non-federally enrolled long-term care facilities, many of them smaller in nature, that will be the local health department's charge to vaccinate as part of 1A. And then 1B and Phase 2 use some age criteria that you can see, maybe from that slide, to prioritize groups. And in particular, Phase 1B, because of very limited vaccine supply, North Carolina Department of Health and Human Services has further subdivided that into 3 groups. 1B, Group 1, will be 75 years and older, regardless of health conditions. Phase 1B Group 2 will be direct care providers and frontline essential workers who are 50 and over. And Phase 1B Group 3 will be direct patient providers and essential workers regardless of age. So a lot to digest there. There is likely to be more information and much more of that detailed information for Phases 2 and beyond, but that will likely come a little bit later. We're getting those deeper dives and those more detailed documents as we move into phases. And I know in the past, our board members have been interested in our homeless population and other congregate living facilities as to where they will fall. And I just wanted to mention that currently, if they meet the age requirement for any of the other phases, they are eligible for vaccine there. So if they are over 75, they can get vaccinated in 1B. If they're over 65 and meet that criteria, they can get vaccinated at that time. Otherwise, they will be, that over 65 will be in the early stages of Phase 2. Otherwise, if they meet none of those age requirements, they will be in the later phase of Phase 2, as it is tentatively planned right now. And I just wanted to share that, as I said, DHHS has put out guidance documents that provide a bit of a deeper dive, is what we're calling it, to help folks understand where they fall in these vaccination prioritizations. I won't go over it in great detail, but you can see here, this is that 1A that we've been focused on since we received vaccine on December 21st, and really has to do with the folks who are caring for, evaluating, testing, doing procedures on COVID positive, or caring for the dead of that. And then the deeper dive in Phase 1B, just went over that in detail, so I won't cover that much more, only to say that this 1B deeper dive has been posted so that as we move into that phase, we have a little bit more clearer expectation, not only from those who are going to be vaccinating, but from the community at large about where they might fall. And per the state memo on December 30th, the local health departments are expected to enter this phase by January 11th. Some of them may be ready to do it on January 6th. They can't do it any earlier than that, or not recommended to do that, and the expectation is January 11th. Due to our vaccine supply, we will begin January 11th. Our vaccine rollout is heavily dependent on what phase the state wants to go into and how much vaccine we are receiving. And so I just want to reiterate that opening up appointments for new phases also is heavily dependent on how much vaccine we get. So we might get an estimate of how much vaccine until it is actually at the health department. We're being very cautious as to open up appointments, because we would not want to open up 975 appointments and then not receive that amount of vaccine.
And Stacie, when do you expect to get the estimates?
So we usually get them just a few days ahead of their arrival. So week 1, we got 700, and that was December 21st. I'm sure that Fletch is covering this. Mm-hmm. We received that December 21st, and we're able to turn that around in 24 hours and start vaccinating people on the 22nd. So just an amazing feat for public health and emergency management and our other partners. And then December 30th, we received 975. and began using that on this week, January 4th. We are expected to receive another 975, but as of the time that I came into this building, we had not received it yet. So, which is, again, planning to vaccinate on January 11th, but hesitant to open up those appointments just yet until we receive it.
And that's like a 1 week supply? Like that's the amount for that week is 975?
We get them by week.
Okay.
That's correct.
Okay.
And it varies.
Okay.
And then I've sort of talked about this already. Phase 1A is quite restrictive, and communication within that group really happened through our provider networks, because those were mostly either healthcare providers or healthcare support staff working with COVID. Phase 1B, Group 1, is also very restrictive to that 75 and older, and we'll be finalizing our messaging for that public release by tomorrow. And when that shipment comes in, be able to start alerting to people how they can get their appointment. Movement into the phases, as I said earlier, is prescribed by the Department of Health and Human Services, and movement in those phases at a local level is heavily dependent on how much vaccine you actually have on hand. So key messages before I turn it over to Fletch, that I just wanted to let folks know that I recognize, for folks who are listening to us and streaming live, that we are definitely growing weary. I understand that. I know people are tired. And I not only do that, I understand that, but that your public health, your emergency management, your hospital workers, your outpatient providers all understand how very heavy and tiring this can be. But I want to urge people that if we want this to end, we still have to be very diligent about some other things while we wait for vaccine supply to increase. And that means stay at home, limit your interactions, use the 3 W's, even with family and friends. When you know them, you trust them, still use the 3 W's, and get your vaccine when it's your turn. That vaccine is an incredible gift, and we're all very excited about it, but it's going to be weeks before we have a supply that can really meet a community demand. And so until then, we are really urging for our community to help us, which means to follow the 3 W's and limit your interactions. And so with that, I'll turn it over to Fletch, who's going to go over our local vaccine rollout.
We've got a couple questions. Maybe I should wait until after. Okay, I'll wait. Thank you.
Good afternoon, Fletch Tove. So talk about our rollout operations at our fixed sites. The actual first week of vaccine distribution in North Carolina was December 14th. During that distribution, public health in Buncombe County did not receive an allotment that was dedicated specifically to hospital systems. Our first allotment for public health was December 21st, and that was 700 doses of Moderna. And that was for us in phase 1. As you see, on the 28th, we got 975 doses of Pfizer. And then we did just receive notification during this meeting, since Stacie stood up, that we did receive this week's shipment of Pfizer and of another 975. So during those first 2 weeks over the holidays, we administered 320 doses a week, and then finished up that first round of Moderna earlier today. We had 900 planned for this week. But we're looking like we're anticipating some bad weather on Thursday, so we may have to cancel our site for Friday for safety concerns. But should still reach probably about 600, 700 dispensed this week. Which brings us into next week, which is important for us because we're going to be changing the location of our vaccinations to increase our footprint, which would take us up to a capacity to do 2,000 vaccines a week. With 800 on hand, we'll be able to push through our current supply all next week. So really, we're dependent on our incoming supply because we have capacity to do more than what we receive. So we can only push out what we receive, and we have to, from this, also cover those long-term care facilities, as well. So, and those draw from our weekly allotments as well. So it's really limiting the number we have during these early weeks. So phase 1A, as Stacie went over, was long-term care facility and staff and patients. Of the 90 facilities in Buncombe County that are not covered by the federal pharmacy program, which fall that charge to public health, we're making a planning assumption that there's about 700 beds accounted for, and we know not all those beds are full, so we're making a planning assumption of about 500 doses will have to go to those long-term care facilities, and that's taken from that weekly allotment. So if we get a weekly allotment of 975, those vaccines have to be drawn from that number. We don't get a supplemental dosage. And then we also were doing first responders and other highest risk healthcare providers, which we had a planning assumption of 3,000. So while we were in the state in phase 1A, our total allotment was 1,675 doses for about a 3,500 needed doses. For phase 1B1, which we're going into, the state is allowing us to go into the 6th, but we will be going into on the 11th. We're making a planning assumption for that 75 or older based on census data that we have a burden of about 40,000 people in Buncombe County who will require that dosage. And we know that there's going to be some hesitancy. We know that some of that number will be covered by phase 1A, but for planning assumptions, we're making that number 40,000 with a current allotment of 1,000 doses a week, which also has to cover the remainder of phase 1A. And the state has allowed us, is planning for phase 1B1 to go for 2 weeks. So you can tell that that math doesn't add up. If we're getting 1,000 doses a week to vaccinate a population of 40,000 and that phase is 2 weeks, clearly we're not going to get there. So I think the mentality we need to see these phases in is not that phase is dedicated to this specific group, but that phase is kind of like a head start for that group as the phases advance to phase 1B2 and then phase 2. Phase 1B2, which will be following next, is going to open it up to age 50 and plus, healthcare and frontline workers of that age group. And we're making planning assumptions of about 5,000, but it's really hard to drill down what that number will be. But we are hoping in the coming weeks, we'll see our allotments increase greatly from the 975 or 700 we've gotten so far. We also, for those long-term care facilities, we have to engage in mobile vax operations. As I said, there are 90 long-term care facilities not covered by that federal pharmacy program, which covered for public health to cover. 700 licensed beds. Again, we don't think they're all full. We think for planning, there's about 500 patients we'll have to cover, assuming there will be some hesitancy we've already seen from those groups. So maybe not even that much, but that's our planning goal. And we'll start those mobile vaccines this Thursday, and they'll be going out, taking those dosage to those groups. And again, those are pulled from our weekly allotments. So for the expansion of our vaccine operations, North Carolina DHHS determines the timeline for these phases. And the limiting factor on our throughput is the state allotment. So next week, we'll be able to burn through all the vaccines we have on hand, and we'll be dependent on the following shipments and pushing those through. We're relocating our fixed site to AB Tech next week, which will increase our weekly capacity to 2,000 at our fixed sites. We're also planning for a future relocation to the old Sears building at the Asheville Mall to establish a permanent mass vax operations site for the county for the remainder of the year. I do want to point out, anecdotally, as I was speaking to people in the community through town halls or business meetings, people seem to think this vaccine solution is a problem for the spring. And it's really not. This is going to be something we're working on solving for the majority of 2021. So I just want us to be in that mindset that this is a long-term problem, not something we're going to have solved by March or April. I just also wanted to discuss that public health is being extremely supported by emergency services at this time. So when we talk about these fixed or mobile sites, 100% of the logistic support for those sites comes from emergency services staff and personnel. And depending on the site, about 25 or 50% of the manning of those sites also comes from emergency services. So these are really joint efforts between public health and emergency services working together as a unified team. Yeah, you want to take questions on vaccine now, and then we'll turn it over to Dr. Hathaway?
Yep. I have one quick one, and then Parker. Parker, Fletch, the numbers that you just mentioned of the $975 a week, is that only what's coming to Buncombe County government for allocation? Is there an additional much larger number that's also happening in parallel, or is that the total that's our community is receiving?
So right now, the hospital system is getting a much larger supply, and they have to take care of their charge as well. But currently, there are no vaccine going to primary care providers. There's no vaccine going to pharmacies. We're not expecting that till sometime in February. So right now, that's the allotment for the county, and it's all public health charge.
And so that does or does not include the vaccines going through CVS and Walgreens to those long-term?
That does not include, that's a separate federal program that's kind of run even outside the state.
Okay.
But Stacie can maybe speak to that, but they're getting the ball rolling, but they're a little slower than we would like to cover those long-term care facilities.
Okay. I'd love to hear a little bit more about how that's going, and I guess also the state's dashboard has a county map of vaccinations. I assume that those numbers are not included in that dashboard as well?
So I can tell you, sorry, so we do not receive a formal report about that federal program. I'm happy to inquire more about it, but we do not receive any type of report about what is being sort of sent out other than that they are getting a certain allotment of the state's vaccine into that program. What I can tell you anecdotally from talking to our communicable disease nurses who are working with long-term care facilities is that we do know that some of them are starting to get vaccinated or already have gotten their first dose through that program. But I'm hoping that we'll see more information about that. I believe the dashboard that you're seeing is what the state sends to hospitals and local health departments right now, because that long-term care facility is all federal run. It is completely it is completely outside of what local governments and hospitals are doing, and run by a completely different entity. And so I will just say caution to that dashboard because there is a delay in that information too. And the state system, which is called CVMS, while has potential to be a great tool, has a few less than desirable kinks to it right now that require us to use downtime forms and those types of things. So it takes a little while for that to get uploaded too. So there's always a little bit of a delay in there.
And that's the state software that they've developed to monitor how we're doing. Okay.
Exactly. Not surprising that with new software and new systems that there's going to be a little bit of hiccups with it. A new update for CVMS is to occur on or around January 7th or 8th, which will fix some of the bugs that we discovered in the first couple of weeks, and hopefully do a scheduling portal too.
Well, I ask about the long-term health facility situation just because I want to know that it's going well. And so I guess give us a high-level explanation of how that works. Is it Walgreens staff? Is it the staff at the facility? And I guess there's all kinds of news reports across the country of refrigeration and freezer failures, and so I just want to know that it's going well and that they're adequately staffed and have what they need.
So the way that it's supposed to work is that allotment goes to CVS and Walgreens, that then distributes it to their teams that then mobilize and do that vaccination. And as I said, we don't get too much more information about what that looks like as far as like how many they've done, but I'll be happy to reach out and see if I can get some of that information for you and share it with you, but I do not have any of that right now.
Okay, thank you.
Thanks. I have a couple of questions as well. This one, you all covered it, but just for folks listening, just to clarify, as we move into phase 1B, when members of the community over age 75 will be eligible, they can contact the county to make an appointment at that point.
So now that we know that shipment is
Yeah.
here, what will happen is, so we already have the steps in place.
Yep.
So we were being very cautious not to open those schedules just yet. So what we'll do after this is tell folks, all right, we're ready to open those schedules. We have a phone tree ready to be launched, and then the public release that will be launched, hopefully by the end of tomorrow with instructions on how to get an appointment. We know that for that particular population, they're less likely to use devices and social media the way that other populations might. And so we're looking at a phone system for them because we also know that that's important for them to be able to contact someone to make an appointment. And so it will be posted on our website. It will be going out to our media outlets, particularly newspapers and morning and evening news and other spots during TV programming. And then I mentioned on our website, and then the phone tree will be changed to direct them to how to get their appointment.
Thank you for going into a little more detail there. That's great.
Yeah.
A couple more quick questions. Again, this is just a point of clarification. It sounds like the largest issue we're encountering right now is sort of the supply chain side of it, and that's all coming through the state, and there's no other way to get the vaccines except through the state.
That's
and
right.
that problem is probably originating at the federal level.
Correct.
Okay.
That's right. So
And is
we are dependent on the state and federal systems. So the federal system tells the state how much vaccine they will get. The state uses algorithms to figure out how they're going to then deploy it to the 100 counties.
Great. And like what we saw with the PPE issue, is this largely a production side problem that's happening, or is it another set of challenges happening somewhere in the supply chain?
Given that the 2 vaccines were just approved, a lot of it is just ramping up that manufacturing and getting it out. So we knew that the first few weeks would be tough and that supply would be limited.
Yeah.
We are hopeful that as time goes on, we will see that supply be more sufficient and ample.
Great. I know you all are in the deep end of this all the time, so these questions are pretty simple, but I think from a community perspective, these are the kinds of questions we're starting to hear a lot of. I have just a couple more. Looking at those numbers, especially the 40,000 in phase 2, maybe 2 or 2B, 1B, I'm sorry, excuse me, the 40,000, that's very close for you all, the 40,000, and then thinking about the timeline of all of 2021 and the goal of probably vaccinating everyone in the county over age 16, if not more, by the end of the year. At some point, it'd be great to hear y'all's thoughts on capacity needs, both from a staffing and budgetary perspective. I know you're probably already thinking about that, but it would be great to start that conversation. And I think that covers my questions for today.
Yeah.
So thank you.
Thank you. And I did just want to say that Commissioner Beachford, that you had mentioned at our last time that we were together that you wanted some of that update of the economic impact, and we're working on that, and hopefully we'll have that for you soon. So we knew this one would be really big, so probably too much in one setting.
Thank you.
I have a question before you go. I'm particularly concerned about what's going on with the African-American community. Oh, I'm sorry. I'm particularly concerned about what's going on in the African-American community. And especially when I look at the 1B1 of 40,000, I'm in that group, but that still can mean I would get a vaccination, in January of next year? But my concern is, how do we get down to the disadvantaged people, the people who really need it, and who I'm afraid can be forgotten during this process?
That's a really great point. I'm glad you brought it up. As I mentioned, phase 1A was very restrictive to support that healthcare system that is caring for the COVID positive, right? So that was extremely prescriptive as to how that was going to come out. And to a certain degree, even 1B1, which is over 75 and over, is
Right.
prescriptive in its criteria as far as age. But as part of our planning, we do talk about like how do we do this in a more how do we take this out to the community and make sure that we have equity and historically marginalized populations in our mind. With 1A, that didn't necessarily come to fruition because of the very restrictive and prescriptive nature of that group. It is definitely at the forefront of what we're thinking about when we think about what sites are we going to do, what partners are we going to engage with, and what communications we're going to be doing as far as town halls and engaging our community influencers about getting that information out, and also making sure that folks understand that we are limited as far as like what supply we get. So we want to we want to vaccinate people, and we still are limited by the number that we receive. And so, we'll be reaching out not just through the other channels that we did, even through COVID testing and through the pandemic of how to get that information out, but our leaders within those communities to help us get that word out and help folks understand how important the vaccine is. And so, with 1A, that just wasn't as much of the case because of the nature of that group, but definitely things that we're thinking about as we move forward. Thank you.
I've got one more. Thinking about, you touched on this a little bit, but I'm thinking about the homeless, and I'm also thinking about some of our partners with the Family Justice Center that work in the domestic violence space, nonprofits, that sort of thing. It was more clear to me in the previous phasing plan where those folks fall.
Mm-hmm.
So I guess tell me, if you're 40 years old and you work for one of those nonprofits, or if you're a homeless person in our community, where do you fit in this?
So
Healthcare
it will, some of it is dependent on whatever your job is or whatever else you're doing. And so I don't have it right in front of me.
Yeah.
But for 1B, 2, and 3, that's going to be direct care providers. And they do, right now, that's defined as direct patient care, but they, in that deeper dive, really go down into that about what that might mean, like community health workers, right? Some care managers, those types of groups are going to be included in there. In 1B, Group 2, if they're over 50, Group 3, if they are regardless of their age. And then Phase 2 is when we start to see that start to stratify again, with the over 65, regardless of health condition, being prioritized. And then 16 years and up with a health condition that right now is being sent back, being referred to the CDC's serious risk health conditions. And then we see the incarcerated, congregate, homeless shelters, those types of groups falling in. And then the other essential workforce that is not included already in 1B. And so I encourage folks, because I won't be able to recite it,
Yeah.
to look at the DHHS website. And I will say 1A and 1B are pretty set. The rest of them, because we have not gone into them, are still with the asterisks of that's tentative. And as we move into those phases, I would expect that DHHS would do exactly what they did with 1A and 1B and give us that deeper dive document that will help us tease that out a little bit more.
Okay, thank you very much.
Thank you.
I want to follow up a little bit on Commissioner Whiteside's question. I appreciate the work being done to educate folks on how important the vaccine is. I want to dig a little deeper, though, in terms of working with those community partners. Will some of that work, and as I talk, my glasses fog, but will part of that be working with those partners to actually not only help folks schedule their appointments, but get them the transportation, the childcare, the things that they need to leave their homes to get the vaccine? What work is being done on that front?
So still very early with the 1A and 1B pieces, but I imagine, as we plan for further phases, and most certainly when we get into that space where we're talking about going to a very large space, to get those partners together to talk through what is that going to look like? How do we, we were very mindful about the locations going forward to make sure that they're accessible to transportation. Are they centrally located? Are there ways for us to do this so that, can we look at hybrids of walk up and curbside so that you don't have to be necessarily separated within a space? So all things that, multifaceted things that we are thinking through, and as we get to those bigger phases, engaging not only our internal equity work, but also utilizing those community partners who have been so instrumental in that too. So it's still so much to be determined in these early phases.
And I do want to add that we do have an equity work group, and they've been involved, and they will continue to be involved to make sure whatever we do, we're looking at that through that equity lens.
I have one other kind of logistics question or timing question. So we don't know at this time what the ramp-up schedule is going to be like, because we just don't know how many are going to be arriving into Buncombe County. So, but could you talk us through when what you can share about when we do expect to get more of that information? Do we know, or what? When might we get greater clarity on, like, how many we're going to get in January, February, March? Or are we just going to be sort of learning all along the way? And like maybe in the end of this month, we're still not going to know what we're going to get in March. It's just going to be an iterative process, or at some point will the scale up of this vaccine distribution process become a little more clear?
At this point, I can just tell you that it is week by week. We find out our weekly allotment, and usually that's just a few days before we receive it, and then that's what we plan for going forward. The hope is that supply will increase sufficiently and have ample supply so that we can plan further out than that, but that's where we are right now.
Right.
There's no timeline to sort of tell us that by February or March we'll have this much right now.
So can I ask Fletcher to also answer that a little bit, because we have been planning for the 2,000 per week. Right now, we're only getting 900, so Fletcher, if you can talk about the fact that we have that plan. You mentioned it already about the Sears and the AV Tech, but.
Yeah, so there's a couple components to expanding. One is just the staffing footprint, making sure we have enough people. It takes a lot of people to do mass vaccination. Two is the location space footprint. So next week, moving to the AV Tech event facility and expanding the staff we have on hand, we'll be ready. We'll be in a stance to do 2,000 plus a week. And then if we start receiving that much, we'll be able to expand at that point even further to do even more than that. And at that point, it just becomes a matter of adding some more staff and more tables and more vaccinators. So we're ready to greatly increase our capacity as soon as that allotment comes in.
And again, so if we were doing 2,000 a month, 2,000 a week, which is around, let's say, 9,000 a month, that's just what the county itself is administering.
Mm-hmm.
Is the expectation that that's just a relatively modest percentage of the total distribution in the community? Of course, we're all just really eager to understand, like,
Right.
by January, February, March, April, what percentage of our community is going to have received a vaccine?
Well, we know in February, we're expecting for primary care providers and pharmacies to receive allotments to start doing their own coverage for their charges. But currently, all that burden is on public health. And that, the hospital has resources as well that we'll be able to expand to the community.
And just a point of clarity, by February, the expectation is for the private providers to be completely enrolled and be launched as enrollment providers.
Okay.
And so the expectation is that by February, those other providers like FQHCs, community health centers, other community medical staff would be completely enrolled as providers and be able to launch as providers. It's still unknown if they will be able to get any vaccine allotments at that time.
And most people who have insurance, that's the place where many people will get their vaccines.
Yeah,
Okay.
well, yes, that's what we would hope, except that at this time, they are not launched as providers, enrolled providers yet. And so the hope as the supply increases, as the response goes, that those providers in our community would also then be giving out vaccine. But it's still to be determined when that will happen because of vaccine supply.
Okay. All right, thank you. Thank you, guys. Fletcher?
I just do want to take one moment to ask patients from the community. I know for phase 1B1, where we have tens of thousands of people who may be looking to reserve a schedule for next week, and we may only have 1,000 spots to open, and then the following week 1,000 again. We have maybe 30,000 people trying to vie for those spots, just patients. And I expect you guys will see many emails of people upset at that process, but understanding the constraints we have.
All right. And Commission, I know we're taking more time on this than we have on the agenda, but I think this is very important. So let's take all the time we need to make sure everyone's questions are answered. And if we need to move some other stuff around, we will. Thank you for being here, Dr. Hathaway.
Oh, I appreciate it. Thank you, Chairman Newman. I was going to start out with an update on the hospital, but I think with all the conversation about the vaccine, it's more apropos to just continue that conversation. I sense the frustration in each of your questions and the exasperation behind your masks. I think the masks are probably a good thing for you right now. It's been a very trying and challenging process to comment and elaborate on a few of the things that both Stacie and Fletcher have commented on already. Number one, the county or the state is allocating by county. So when they look at the doses that we've received, they look at the doses that have gone to Mission Health System, and they look at the doses that have gone right now to the health department. And so that's an aggregate number that they look for future allocations. The dashboard that you're looking at the state level that documents how much vaccine has been given is wildly inaccurate right now because, as Stacie Saunders said, that there's delay in the data, and the state vaccination registration system called CVMS has been really fraught with major problems. And we administered our initial series of doses completely on downtime forms. We're unable to administer any doses within the system. So I have confidence that it will come up. It's new. They're working on it hard. But right now, don't draw any conclusions based on that data at this point. We have received almost 10 times as much vaccine as the county has, which is good news and bad news. We've administered 3,700 doses to our 1A healthcare providers, which is good news. We have about that much and a little bit more to continue to administer. I think by the end of this week, I'll have had a total approaching 9,000 total doses that have been that are able to be administered, including those which we have already administered. We, in our healthcare system, have looked at the number of people we think qualify, and when I say healthcare system, that's across the 18-county region, and it includes both employed people and independent providers who work with us, so independent medical providers, advanced practitioners, et cetera. And that number comes to in the neighborhood of 11 to 12,000, give or take. And I have roughly 9,000 doses right now. So if you do just quick back of the napkin math, if we get a 75% uptake rate, we should have enough to cover all those folks. I'm not sure we'll have it that high. It remains to be seen what people are going to do. I think a lot of people are apprehensive and waiting to get it. We fully plan to expand our vaccination within the community to include, when we can, as we move through our own internal tiers, office practitioners and dentists and other people in the community, first responders, et cetera, when we can do that. How I'm going to do that, how I'm going to get it scheduled, what it's going to look like, when it's going to happen, those are all, if you have answers for me, I would welcome your input on that. The CVMS system has been a challenge. Our scheduling system internally has been a challenge. It's not as simple as a massive flu vaccination campaign where we can simply go out and stick needles in arms and not worry about it. We have to document the dose, make sure we know what lot they got, because we have to be sure if there's any problems with this vaccine that we can track the people. We have to make sure that we know where they had the dose administered. The logistics are complicated. So just to echo what Stace and Fletch said about begging patience of the community. That being said, we're making great progress. If we have extra doses of vaccine, I don't want it sitting on the shelf right now, and if we think we can get supply later, we'll do what we can within reason. We talk, Stacie and I talk every week or more often, and we'll do what we can to get the vaccine where it needs to go to get in people's arms. It's really important that that happens soon. I can't make promises about what that'll look like, except to say that we'll collaborate as we try to come up with a community solution. If you look at the total numbers, if we want to vaccinate 70% of the state of North Carolina, and we do a ballpark estimate of that, that's 7 million people, assuming 10 million people, and we divide that by 365 days of the year, and 2 doses per person, we have to do 40,000 vaccines a day. And if you look at our testing right now and how long it took us to get to testing, I think you can appreciate the scope of the problem. If we look at 275,000 people in Buncombe County and we look at 250 doses a day, that's only 90,000 doses in a year. So this is going to take time for us to ramp up. It's incumbent on us who are charged with this responsibility to work collaboratively across silos with one another to really build the infrastructure to make this happen. They can't do it alone. We can't do it alone. This is going to take everybody in the community to make this happen. And so we're working actively with the team to try to do that. I wish I could give you more details about what the slope of the curve looks like, when we're going to hit these certain landmarks. It's critically dependent on lots of other issues. And I think you heard just before this meeting that the governor has talked about bringing the National Guard in to help with some of this. It sounds like, the white horse is on the way. That's every little bit is going to help, but that's just the beginning phase. We need permanent places, long-term solutions, and a long-term strategy across multiple organizations to get this done. So we'll work on that. Any specific questions for us about what we're doing at the hospital at this point, or anything I can further elaborate on?
I wanted to ask within something you mentioned, I guess, what do you view the hospital's responsibility in vaccinating folks through these future phases beyond phase 1A?
It's a question that we're actively addressing right now. The hospital, the state has deployed the vaccines in two different ways. One is a closed pod and one is an open pod. And we applied for closed pod distribution, which meant our healthcare facilities and the workers and other people affiliated with it. We are planning to step outside those bounds a little bit to make sure that we address all the other folks. But I don't want to make a global commitment at this point in time until I know what we can handle without massively disrupting our other operations, which I'm going to talk in a moment, which is caring for all these COVID patients, which are washing up on our shores in droves. So we're really, we got a double responsibility here. We will do what we can. We want to help. We'll cooperate and participate in any way that we can, but I can't make detailed promises about what that'll look like right now.
Thank you.
So that gets to the next question. I appreciate you asking that. The next issue is what's happening in the hospital system. I think people are aware that we have seen more patients, not just at Mission Hospital, but at all the HCA facilities. And I have daily calls with the other CMOs in the region. Part E, as an example, it was in the 30 to 40 range. They used to have less than 10 patients. Haywood County was over 25 today, Haywood Regional. Harris is above 20. Advent was pushing 20. And these are all facilities in the region which had less than a half a dozen patients for most of last year. In November of this past year, we had 40 patients in our hospital. And today we are at over 130 at Mission. So we've more than tripled our numbers in 2 months. We knew that would happen, that it would rise as the result of the Thanksgiving holiday. What surprised me was that the rise occurred even before the holiday began. And you saw the numbers that Stacie showed, the epi curve for Buncombe County, exactly the same shape of the curve for our hospitalizations, just a different y-axis, of course. So it is hugely concerning to us that the numbers continue to rise, and we, as Stacie has, and I have in other forums have repeatedly pleaded, we absolutely need the community to do everything they can in the privacy of their own homes and friends and family gatherings, which we hope are minimal, and then in the community to minimize the spread. We're often questioned about what our capacity issues are at the hospital. We have a complicated, I shouldn't say complicated, a sophisticated and complex set of metrics that we look at to determine how we're doing. Percent of patients in our ICUs who are COVID related, percent of patients on ventilators, percent of ventilators used, PPE on hand, et cetera. It's a detailed spreadsheet which I brought with me in case there are any specific questions. I don't think the details matter for the purpose of this conversation, except to say that we look at this every day trying to determine how our capacity needs are being met. We went on a big campaign to hire additional nursing staff. Our biggest concern is not beds or PPE. Right now it's nursing staff. That's human capital is a finite resource and a valuable one that we need to really take care of, and they're getting worked very, very hard right now. We've had to stretch our ratios, as have the other hospitals in the community, as has everybody across the country. You're seeing that nursing shortage is real, and we're doing everything we can to meet that need. Right now we're okay. It's not where we want it to be, but I'll use the okay in quotation marks, and we're watching that closely. We're often asked about procedures. If you remember earlier in the year, there was a move to curtail what we called non-essential, and I always struggle to find the right word because the procedures that were stopped were essential to the people who were needing them, and we have to be mindful that when we term something elective, it only means that it's not a hyper emergency. But if you had a breast mass and you needed it removed, that would not be considered elective in most people's eyes, but in many ways it was previously. We look at the procedures that we think might occupy an inpatient bed afterwards, and are watching that closely. And if and when we get to a point where we're at capacity pressure points, we'll focus on those procedures first, stopping surgeries and procedures in the outpatient setting in the ambulatory surgery setting doesn't do anything to free up resource, and it just delays care. So I raise that to you all because I appreciate your concern from prior conversations. I share that concern, and I want you to know that we look at it as a dimmer switch that we slide up and down to increase capacity, as opposed to a light switch that we turn off and on to help other people. Those, I think, were the bulk of my comments that I wanted to add right now, and happy to take any questions if anybody has any.
Dr. Hathaway, thank you for joining us today and for this candid update. Several providers I know locally had said they feel that we're already in the surge, not that it's coming, and I wonder if you would agree with that assessment.
We are. I used to talk about the lapping at our shores, kind of euphemistically, because we were isolated geographically here, and when we hit 40, I thought 50. How are we going to handle 50? We've learned how to handle it, but we are deep in the surge right now, and it's going to get worse. The numbers are going to go up higher. We will have somewhere between 150 and 200 patients in the hospital. We're preparing for that. I raise that for two reasons. One, to provide some level of reassurance that we're planning for it, and also to really tell the community that this is real and we need your help. The solution is not stopping elective procedures. The solution is not coming to the hospital in the first place with COVID, and so we really, really need everyone's help in that regard.
And as we do that scenario planning, is it the staffing capacity that's really the highest level of concern for y'all around being able to manage increased numbers?
I think so. I think physical beds is less of an issue. We plan for that, and then now what we're seeing is the staffing issues will be the thing that limits us the most.
Right. Another question I've gotten from community members is, if we start to see other parts of the state exceed their capacity, are there plans where the sort of overflow would come into the Western North Carolina region?
Yeah, I've thought about that question a lot. It was asked previously. We made a decision. So our acceptance of transfers is a very complicated process. It's dependent on bed availability, and it's dependent on skill set to take care of the patients. And it's dependent upon recognizing that we see the 18-county region as our priority and our responsibility. And so there have been times when we've, stopped transfers from out of state for inpatient beds because we wanted to be sure that we've had that capacity. We're in medicine because we're humanitarians and we care about people. We don't want to see anyone in trouble, but we will have lots of conversations about how we globally manage that across the state. There are state calls with the North Carolina Healthcare Association that we're on every month, and I pray that doesn't become the issue, but we'll take patients from wherever we need to when the demand arises.
Thank you.
Yep.
Of the 130-some patients you have with COVID, how many are residents of Buncombe County?
Oh, that's a really good question. I would think probably 75 to 80%, but that's just a guess. When you look at our hospitals across the region, and we have hospitals in Highlands and Franklin and Angel Hospital, Transylvania, McDowell County, and Blue Ridge up in Spruce Pine, we have 160 patients. And obviously the sickest patients come down here to Asheville, but all the smaller hospitals, the Duke Life Point hospitals and the Pardee and Advent, they're all learning how to take care of these patients too. So their acuity is rising, but total 160 in our system and 130 in Asheville.
Dr. Hathaway, when you say, we've gone from 40 to 130, of course, that's very troubling, and it's going to keep growing. Realistically, we could have 150 to 200 patients in the hospital. Like you said, you have some levers, right? There are things you don't want to defer, but if we absolutely had to, you could do those things, trying to bring in new staff. What do you see as sort of where, the capacity of the hospital, when you sort of start running out of options, and the scenario of where we talk about facilities being overwhelmed, like we get there and there's really not other good short-term solutions to it. Like,
yeah,
what do you see that as?
Again, there's not a single point, but I think conceptually, when we get to a point where we can't routinely accept transfers from the region for whatever is bothering people, because remember, the strokes and heart attacks and kidney failure and everything else is going on. So when we get to a point where that routinely becomes a problem, then we need to look at how we create additional capacity. That's probably one of the things that worries me the most, because we're not just a COVID hospital, we're a tertiary and quaternary care hospital where we care for everybody in the region. We recognize that responsibility. So that would be one. If the staffing ratios to accomplish the care are just untenable, that would be another one. And I recognize that, anything that's not what is normal is untenable for those who are providing the care of those patients. And it's important that I take a pause here just to thank the people who work in our facilities, because you've heard it since the dawn of the pandemic that they're the heroes, but now they are really doing the heroic work here, and I just want to recognize that we acknowledge that. So the staffing ratios, go ahead.
And I realize there are these different ways that you can help manage this, and these numbers don't stay fixed in time because of different things that can be done. But I mean, is it possible for the hospital to share with us, community, you need to know, like, we have this much more capacity, but if we go beyond this point, it's going to be really bad for the folks who are getting sick from COVID or something else. And the other question I would ask would be, what are those ratios which, if we go beyond them, really are considered, that's unacceptable? And are those things that can, because we all anticipate the next couple of months are going to be really tough. And I guess just to the extent the community can really understand those dynamics, whether it's good news or bad news, I think it's just,
as
it's
examples,
helpful.
without getting too much into the specifics, if we have a nursing unit, which typically one nurse cares for 4 or 5 patients, and because of 6 staff members or extra patients, they're up to 1 to 6 or 1 to 7. While that may work for a short time, that's not a good long-term solution, okay? And that's when we have to adjust. I think we have to remember that not all of our staff members are created equally, in the sense that if I shut down orthopedic surgeries, those nurses may not be able to take care of a medical surgical patient necessarily. Nonetheless, they're better than no one, right? And I hope we don't get to that situation, which was what was going on in New York City and probably in Los Angeles right now, where they're really in a bind. And so from your question, the perspective of your question, if the community wants to know, are we at that point? I consider us at that point. Anytime that we have this many patients with COVID and we can do something demonstrably to prevent people getting the illness, we should be doing that. You owe it to the people who are taking care of the patients in the hospital right now. You owe it to your friends and neighbors and your families to do whatever you can to stop the spread of this.
Okay. Commissioners, any other questions for Dr. Hathaway? Thank you for being here.
Yeah, I appreciate it, and we'll keep you up to date on our receipt of vaccine, and we'll communicate weekly. We have a weekly call with Stacie and others where we'll keep them up to date, and we'll make sure that we share the wealth and spread the vaccine.
Okay, thank you.
Yep.
All right. Avril, are there any other items on this agenda item? And I realize we took more time on this, but I think it's just very important to get this. Anything else we need to cover on this today?